the corneal topography report. It has got three components. One is a map, the second is a cursor block, and the third is corneal statistics. So of course we start by writing the name of the patient, one, number two, the date, number three, which eye, OD or OS, number four, five, the scale. This is important. We will consider that. Number five is the map. Number six is the statistical information. This one. So I will touch each one by one. Now, statistical information, and if we want to check the previous maps of the same eye, or we want to check the maps of this eye with other eyes, we should have the same scale, and the scale can have different gradients. For example, one diopter differences, half diopter differences. We will see that. Okay, so this is the cursor scale. Now, the radius, power, meridian, axis, distance. By default, the cursor is in the center. So it gives you the power of the center. Later on, you can move the cursor, and this cursor box will give you the details of the point where the cursor is. And the second is statistics. In the statistics, you have SRI. You will see what is SRI and what is SAI. All the participants are here. So, and PVA, potential visual acuity. We will see in detail one by one all these things. So initially the cursor is in the central position, default position at the corneal apex, and the cursor box gives those readings. And later on, the cursor can be moved to any other position, and then the cursor box will give the position, the reading of that position. So,
sir, please zoom in the slide.
Okay. So can you see the slide?
Sir, the slide is visible, but it is in the background. It's very small, sir.
Okay, so actually, difficult for me.
सर आपकी आवाज भी बहुत कट रही है.
Okay, so I will be a bit loud, but this is, if you can see, this is the statistics block. They are headings SRI, surface regularity index, SAI, and PVA. So we will see each one by one. So this is the potential visual acuity PVA number 3 index. It gives us the range of visual acuity which could be expected if the cornea was the only factor limiting VN. Corneas with irregular astigmatism have lower potential acuities. So regardless of the state of the retina and the lens, if we consider everything all right, then only the corneal condition, its surface, its regularity will give how much VN. This is the index, potential visual acuity PVA. So if a cornea is very irregular, scarred, PVA will be less. But if a cornea is in a good shape and has a slight astigmatism, PVA will be more. So okay, now consider this one. This is Google Map, and you can see that it has been color coded. You see the heights of the mountains have red color, while the valleys in between have green color. Similarly, we want to draw the corneal topography, and this is the concept of best fit sphere. For example, this is the green line is of cornea. So if we want to describe the height of all the points, then we draw a best fit sphere. This orange line is a sphere which is called best fit sphere. And then we describe each point of the cornea in relation to this best fit sphere. Each point of the cornea is how much elevated, what is the height of each point of cornea above this sphere, and what is the height of the cornea below the best fit sphere. So we describe the corneal shape at each point in relation to a best fit sphere. You can see you can have a color coded scheme. So again, this black line is a cornea and this yellow line is a best fit sphere. So all the points of the cornea which are above the best fit sphere will be coded red, and all the points which are below the best fit sphere will be coded as blue. So the red will be a warm color and the blue will be a cold color, and you will come to know instantaneously that okay, of this cornea the center is too much elevated and the periphery is too much depressed. So this is the concept of elevation and best fit sphere. This is the primary importance. Coming to the cornea, you will see that here in the center the cornea is coded red. That means in this three-dimensional map, the cornea is too much elevated from the best fit sphere. While if you see, this is the green line, this means it is on the best fit sphere, and this is the blue circle surrounding in the periphery. This means this area is too much depressed or too much at a low level than the best fit sphere. So this is characteristic of keratoconus. In keratoconus, we have a central cone which is above the best fit sphere, and we have a periphery which is below the best fit sphere. Now, another way of depicting it, you see in the cone area, the cornea is elevated and it is coded red. And in the periphery, it is, this is the color code, red means elevated. And this is the orange color, means this has got less dioptric power. Okay, so coming to the maps which we have, we usually have four maps. The anterior elevation. So each point of the cornea is how much above the best fit sphere. And as we saw earlier, the red portion is above the best fit sphere. The green portion is at the level of best fit sphere, and the blue portion is below the level of best fit sphere. So if you compare the anterior elevation, this one, with the posterior elevation, you will see the posterior elevation has more warm color, about violet color, in addition to the red color. And the violet color has more elevation than the red color. So the posterior elevation is something which has caught our attention now. Previously, we were concentrating on two aspects of the keratoconus. One is the corneal power and the second is the pachymetry. Now, this is the third most important thing that usually is considered to be most pathognomic of keratoconus, an increase in the posterior elevation. Now, this is the concept of radius of curvature and global versus local. I will not go into details of that. The scale step interval is important. You see here, the scale step interval is more, about 1.5 diameter, 1.5 diopters. So you are not picking up any corneal astigmatism and corneal red color or steepening. But in this map, the corneal step scale is 1 diopter. So you are picking some detail, but not all. And here the scale steps have been reduced to 0.5 diopter, and in this area 0.2 diopter. So all the four maps belong to the same cornea, but each map has different scale steps. So you can see the varying the step intervals can have a different sort of representation of the cornea. So the first thing we look at the corneal map is the scale, and we want to see whether it is a 1 diopter scale 1.5 diopter scale, 0.5 diopter scale, or 0.2 diopter scale? What is the interval? Normally 1 diopter intervals. So can anybody tell me what is the normal cornea out of these four? What are the difference between the two? So this is, you can say this is a regular one, the circular one. This is slightly oval. This is having a bow tie appearance. Here the bow tie is more asymmetrical, more red above and less red below. Here the brown is almost equal. So this is a symmetrical bow tie. So actually all these are normal corneas. These are the different shapes by which normal cornea is represented in topographic maps. You see, round is present in 23% of the cases, oval is present in 21% of the cases, and lesser number are of regular bow tie and asymmetric bow tie. So remember, all these patterns are normal patterns. Slight asymmetry of the bow tie is not something to be afraid of. Now, what is the problem in this scan? Anybody? This is the scan, and after a few movements, we took the scan of the same cornea again, and it was now in a better shape. So what is the difference between the two maps? There are a lot of black areas in this map, and this shows the movement of the eye, misalignment. And that's why this is the map on the left side is of poor quality, while the one on the right is of good quality, and this is the map of the same eye a few seconds later. So this is basically an artifact because of the misalignment. Okay, and what about this one? Again, black spots which show the lack of the data at these points. And the lack of the data is because of, we ask the patient to blink a few times, and after a few times there was no more tear film irregularity, and after blinking a few times the corneal map was of regular shape. So do not comment on this corneal map which has deficient data points, black spots. So you should ask the patient to blink a few times and to improve the sort of alignment, and then take a map again. Okay, so coming to the concept of tight sutures and light sutures. The tight sutures make a depression or a dip at that point, and this results in increase in the curvature, and while the opposite is true for the loose sutures. The tight sutures are equivalent to cautery at that point, which gives rise to a tissue contraction. Right? So we will see now. This is post-keratoplasty corneal map, and you can see there is a bow tie. So these points, 0 and 180 degree, there the corneal sutures are tight, and this gives rise to an astigmatism, and these points have more dioptric power. So these are the warm colors, while the blue colors, which are present on 90 and at 90 degree and 270 degree, they have a cooler color. So it means the astigmatism is less at these points. So the warm colors are the points where the stitches are tight. So this is a horizontal red bow tie, regular corneal shaft astigmatism, and the sutures are tight at 0 degree and 180 degree, and this coupling results in flattening of the opposite meridian. So remember this photograph, this is just like a bow tie which the men wear sometimes with a formal dress. So this is a regular astigmatism. Now, the cornea ectasia, we have different types of ectasia: keratoconus, keratoglobus, pellucid marginal degeneration, and there is considerable overlap between their clinical features. So it is difficult to put strictly in one category, whether this is a case of keratoconus or globus. Sometimes it's difficult to say and may even coexist in an individual or in the same family. So rather overlapping spectrum in most of the cases. So what is the role of topography in keratoconus? One is diagnosis. We want to detect the subclinical cases. And we do the topography before refractive surgery to screen. And we want to differentiate between a keratoglobus and pellucid marginal degeneration. And we want to see what is the severity and location and shape of the keratoconic cone. Then the role in the management. So what is the role in the management? We want to monitor the disease progression, whether it is increasing or not. And we want to, when we want to fit a contact lens, we want to have the basic data, how much cornea is curved, so what type of corneal lens will be required. Similarly, in penetrating keratoplasty, we want to see the preoperatively at what points the cornea is more steep, and similarly post-operatively at what points the cornea is more steep. So anybody can comment on this one? Now you have the knowledge. What is this? Is this a normal one or an abnormal one? Any comment?
Sir, this is the corneal curvature map of the right eye. That is showing the symmetrical bow tie with more steepening superiorly.
Excellent. Excellent. So this is
Hello?
asymmetric. You are very right. This is asymmetric bow tie with more astigmatism in the superior quadrant or superior half. Right. So this is basically a keratoconus cone, and this is the tip of the cone or the apex of the cone. See, there are different shapes and different locations. One is oval, so the other may be globus. And this is an example of an oval cone. Then can anybody comment on this one?
So this is again the corneal curvature map of the right eye, color-coded corneal curvature map of the right eye, and that is showing central of steepening, which is cannot this into words.
Okay, good. So this is again a keratoconus cone, but the central steepening is too much. So this is an example of nipple. Central cornea almost spherical, much steeper than the periphery. So the warmer color is in the center, but localized one. Okay, so the next one, what about this cone? Where is the apex?
So superiorly, the apex lies superiorly.
Superiorly. So in this case, it is lying superiorly, but in most of the cases, it is inferior or infrocentral. The superior one is only 17% of the cases. So keratoconus cone can lie at any location, but usually it is close to the central position. Now, what about this one?
So inferior, the cone is lying inferiorly.
Good. So this is infrocentral. And what about the severity of astigmatism? Is it bow tie appearance or very asymmetric pattern?
So it's not, it's a cone, it's inferiorly located cone, not a bow tie pattern.
Good, good. So it is a cone which has been, there is localized steepening and the corresponding flattening in the opposite hemisphere. So what about this one?
So the artifacts inferiorly, so we cannot comment on it, but there is severe keratoconus inferiorly, severe steepening.
So there are a few blank spots, but there is steepening. The cone is present inferiorly, right? So what is the lesson here? This is anterior and this is posterior. Can you make out a difference between the two?
The posterior one is more
Actually, sir,
steeper.
Good. So the posterior one is more steep because in
yeah,
anterior one has red color, but the posterior one has a violet hue. So this is more steep. The posterior elevation is more than the anterior elevation. And so this is the anterior one has a power of 53.7 diopter and the posterior one has a power of 67.4. So this is characteristic of keratoconus. This is the third criteria in addition to the power and pachymetry, that is the thickness of the cornea. Right. What about this one?
Axial power is more steeper.
Okay, in the
axial
center,
power
and where is the
center.
thickness? The minimum thickness is present at
Just below, so just below the epic.
good. So these are the other indications. So what? Again, look at this map, and can you see any finding?
Say the first map, there is inferior central
Okay, so
steepening.
what about this one? This is front elevation, and this is back elevation. Any difference
So,
between the two?
actually, sir, this is the two elevation maps, the front and back elevation. In keratoconus, the changes on the back elevation start early. So
Good.
that can be helpful for us to diagnose the early stage of keratoconus. In this stage, we can see that on the front elevation, there is no changes, but on the back elevation, the changes have started. So that is basically early keratoconus.
Good. So and this is the sagittal map or the axial map, and this is about thickness. So now you have the basic concept of four maps, which are usually we are to quantify. So what are the advantages of keratoconus indices for quantifying the severity of keratoconus, tracking progress over time, and detection of subclinical cases? Now, the basic question when the topography map comes to us in most of the cases, does this patient requires CXL? Can we do refractive surgery? So we have
no.
two answers, and that's why we want to have the corneal mapping. And we want to compare the effects of different treatments. For example, after doing intakes, we want to see what change has occurred. Okay, so these are the different indices. One is surface asymmetry index. And this is difference in the corneal powers between points on the same ring 180 degree apart over the entire corneal surface. So on one cornea, on the opposite sides, the power is compared. The point on the superior part is covered with the point on the inferior part, and one on the nasal part is compared with the point on the temporal part. So this is surface asymmetry index or SAI. Another one is surface regularity index SRI. Local, it detects the local irregularity within 4.5 millimeter and compares power of each point with that of its immediate neighbors. The previous one was comparing it with the opposite point. This one is comparing with the immediate neighbors. So SAI and SRI. The third important index is inferior superior value, IS value. Average refractive power difference between 5 inferior points and 5 superior points, 3 millimeter from the center at 30 degree intervals. And these are abnormal in keratoconus, as we have seen that in keratoconus, many a times the cone is inferiorly. So there is a difference between the superior half of the cornea and the inferior half of the cornea. And this IS value is disturbed whenever the points in the inferior and the superior part of the cornea are different. And similarly, after penetrating keratoplasty and large incision cataract surgery, the cornea is D-shaped so that the two halves, the superior and the inferior half, have different dioptric values. So we have discussed three indices so far: SAI, SRI, and IS. Now, difference in the central part may be due to keratoconus, and we know that more steepening in the center means keratoconus. Now, this is the index which uses many indices: keratoconus prediction index (KPI), and it is derived by inputting 8 quantitative indices into an automated keratoconus detection algorithm. It's not perfect, but has a sensitivity and specificity limitations, but accuracy is about 90%. So this is KPI, and all the 8 indices which include the ASI and SAI and SRI and IS, all are included in it. Now this is more, you can say, latest one, the Bellin Ambrosio enhanced ectasia display. It combines the elevation and tachymetry map, the enhanced best fit sphere, and in the 8 mm and regression analysis of all the thin points, tachymetry, thinnest point, anterior and posterior elevation. So all these points are considered, and then this bad analysis is done. So coming to a corneal graph, can anybody explain where are the tight sutures and where are the loose sutures?
The tight sutures are at 120 degree and superiorly and inferiorly.
So 120 degree and inferior
Sir,
point.
at 11 o'clock, sir, at 11 o'clock and at 5 o'clock.
Good. So you see where are the warm colors. We have 10 minutes left, and we will try to do a.
So 120 degrees superiorly and 300 degrees inferiorly, or easily for our convenience, we can use clock hours. 11 o'clock,
So
10
you see,
to 11 o'clock. Inferiorly
where are the warm colors? The red color is here. So the steepening is at 15 degree and 195 degree. These are the cool colors. So cool colors mean the sutures are loose. So sutures are loose at 120 degree and 300 degree. Right. So this is a regular astigmatism, and the loose sutures are at 120 degree and 285 degree. So what about this one? Where are the warm colors?
45 degree and 210 degree.
Good.
220.
So 230 degree meridian is more steeper. So you will require to remove more sutures from this quadrant than from this quadrant, because this is more steeper. Okay, so sutures need to be removed from 90 degree arc inferiorly, but only from a 20 degree arc superiorly. Right. So what about this one? Is there too much astigmatism or too less astigmatism?
Too much.
Too much. So we removed the tight sutures, and what is the now the astigmatism has reduced. Okay. So now come to this question. There was an ECC 12 mm incision, and we closed it with 5 interrupted nylon sutures, and keratometry and refraction tells us that the steep axis at 115 degrees. So where will you remove the suture? At steep axis or at a flat axis?
The flat axis is tight suture.
No, the tight suture is steep axis. So you want to remove the suture at steep axis, right? But this is from keratometry. Now here comes the role of the corneal topography. When you do the topography, you see there are 2 points where the warm colors are, right? Yellow is warmer than the green. So you come to note that there are actually 2 points where there are tight suture and you want to remove the 2 points at, let's say, 130 degree and 40 degree, not at 115 degree. So this is the benefit of corneal topography, that you come to know exactly where are the tight suture, and you remove the sutures and astigmatism is reduced.